Morning, everyone. Just be a moment while everyone joins. Apologies for starting a minute late. I had some technical difficulties at my end, but they're sorted. So I'll just give you another 10, 15, 20 seconds as people join, almost one a second, and then we'll get started. In the meanwhile, it's really helpful if you can put your name in the chat and say which country you're on. I'm in NAM. And to say perhaps, what you're looking forward to getting out of today, or to share anything else that you feel comfortable sharing. In a moment, some slides will come up. And I think we've got more than half of folks here, so I will start in a moment. Just mention we've got a couple of things open. There's a chat area where you can go and just put your comments, like where you're from, where you are today and the like. In addition, we've also got a Q&A section. Now, we do have some questions some of you asked when you registered for the webinar, but you're really welcome to ask more. We might not get through all of your questions today when we stop at the end for some question and answer, but we keep them, and we look at them, and we use them again in our advocacy. So even if you think, I don't know if they'll get to this today, but if it's relevant to this topic, pop it in. We'll try. If we don't, it is never, ever wasted. You might have noticed the session's being recorded, which is our standard practice. And I would just think that now it looks like there's enough people here for us to get started. So we might move on to the next slide and get going. Great. So I mentioned I'm in NAM. I'm on the land of the Wurundjeri people of the Eastern Kulin Nation, and I'd like to pay my respects to their elders past and present, and acknowledge their continuing relationship to the land and waterways here, unceded and, of course, always theirs. I'd also like to acknowledge any Aboriginal or Torres Strait Islander people who are with us today on this call. Extra special warm welcome to you all. And I would like to pay my respects to the elders of the Wurundjeri people where I am here, but also to all elders and people who have other people have perhaps connection to this land or other lands that they're on today. So almost finished welcome, background and purpose of session. You'll be pleased to know, because then we get to the interesting part, which is Professor Mark Cormack giving his presentation and talking about what it is that the Scope of Practice Review has been doing, where it's up to right now. After that, as I mentioned, we will have a question and answer session, which will be very helpful, as I said, for you to pop your questions in, and we will be using the questions that were discussed, that you provided earlier on. Great, thanks. So for those of you that don't know me, I'm looking a little bit better there in that photo than I do today, I think, but we have our good days and our bad days. So my name's Elizabeth Deveny. I'm the Chief Executive of the Consumers Health Forum of Australia. We're the national peak body for all Australians, whether they're using the service, they're paying for a service, they're caring for someone who's experiencing a health service. We represent everyone, and we advocate on a national level for better health care for all Australians. Of course, today we have, and you'll see there on your screen, Professor Mark Cormack. I'm going to put the Mac in. I'm sure that happens to you from time to time. I apologise, Mark, who's the lead reviewer for this terrific review that's being undertaken. It has been incredibly thorough. So there's kind of an academic rigour to what you're doing there, Mark. They've done many, many roundtables, lots of literature review, really wanting to hear from everyone. And today is another opportunity for them to hear from you what your key issues are that you want the reform team to be well aware of, and any bright ideas you have, send them along, because bright ideas are always very welcome. So the purpose of today is, as I said, to have you as people who use the system think about and provide commentary on how health providers might best support you. So if you think about your own care, the care that you receive or someone you care for, and think about, gee, wouldn't it be great if this could happen, if the providers could come to my home, if it was possible to have two providers and myself in a conversation about something and that would be funded by the government, if it was possible that I could get this service from another provider because I know that they've been trained to do that in university, but perhaps for whatever reason, legislation, regulation, practice, custom means they don't do it right now in my part of the country. So thinking about all of those things, what would best practice look like for you as a person receiving care? So you'll certainly get some background on what that is, and I've kind of started to tease that out a little bit, the review and so on. And also the questions that we really want you to think about in our upcoming consultation. We are going to have a consumer roundtable following on to this, and we'll provide a link to the EOA after this webinar. And being at this webinar, either in person or watching it later on, or both if you really enjoyed it and want to watch it a second time. Sometimes the sequels are better, you'll be able to do that because we'll make that available to you, and that is part of the kind of pre-briefing for this consumer roundtable. Okay, so without further ado, it's my great pleasure to pass you across to the amazing Mark Cormack, who's going to now walk you through the review today. Thank you so much, Mark.
Great, thanks. Thanks, Elizabeth, and thank you to CHF for organising the session today. Thank you all for turning up. I think it's really important to note that this is the first public consultation session that we're holding on phase 3 of the review, and I think it's very important that that we start with consumers, and certainly from the previous consultation sessions that we had, and we did so many face-to-face sessions, online sessions. Arguably the strongest and most useful one that we held was with the Consumers Health Forum. So we're really looking forward to today's session, and as Liz said, the follow-up workshop that we'll be running shortly. So if I could just go to the next slide, please. Just quickly to remind you, just some of the terms we're using today. So what is scope of practice? It refers to the full spectrum of roles, functions, responsibilities, activities and decision-making capacities of an individual working within the primary healthcare professions. It also embraces that which of these activities the individual is educated in, competent, authorised, usually through professional standards or national regulation, and accountable to perform. Important for this exercise, and certainly for one of the reform options today in particular, some of these activities and functions are shared or may be shared across other professions, groups or individuals. And the review is really focused on identifying opportunities to remove barriers that stop health professionals from working to their full scope. But the context for that, or I should say, and the context for that is care provided within multidisciplinary care teams. And we'll hear more about that as we go through the presentation. Next slide, thanks. So background to the review, this came out of the Strengthening Medicare Taskforce Report, went through all the national cabinet and federal budget processes, was announced roughly this time last year as a budget measure, and that's its background. Next slide, thanks. The Strengthening Medicare Task Force was a kind of a landmark piece of policy work by the new government, and it presented a vision of a primary care system which really focuses on 4 things. Firstly, increasing access to primary care. Secondly, encouraging multidisciplinary team-based care where health professionals work to their full scope of practice to deliver quality person-centered continuity of care. To modernise primary care, in particular through data and digital technology, and it also supports change management and cultural change needed to achieve the objectives and recommendations of that report. Next slide, thanks. So here's the journey to date. We're in phase 3, just really at the sort of consultation aspect of phase 3. and phase 3 will run through pretty much to the end of this month, probably overlap a little bit into July. It commenced with the release of the issues paper back in April, which has options for reform to address barriers and enablers. And also we're now in the stakeholder forum and consultation phase, and that'll take us right through to the end of June. And then really the next few months will be spent drafting the final report and an implementation plan. There will be some further stakeholder engagement and input into that before we finalise the report by October and submit that to the Commonwealth Minister for Health. Next slide, thanks. So, an overview of issues paper number 2. I know that most of you would have had a chance to have a look at the issues paper, but this is just a quick snapshot of what it's meant to do. The first thing was it's meant to provide an overview of the evidence that we collected to date, and that evidence came from submissions, consultation, and also a fairly detailed evidence review and literature review. Secondly, on the basis of that, it outlines 8 options for reform based on the evidence, and it also outlines some very specific questions that we want to explore through this consultation phase, and pretty much foreshadows the general direction that the review is proposing, and will also outlines the next steps for the review. The journey to date has really, we've had 2 rounds of consultation, 2 issues papers, the delivery of an evidence and literature review, and we've also conducted a legislation and regulation review. So there's been a lot of activity that's been undertaken over the last sort of 8 to 9 months. Next slide, thanks. So what we now know from issues paper number 2, that we've identified kind of 2 sets of benefits. They overlap. The benefits that have been identified through the extensive consultation that we've undertaken is that health professionals working to their full scope of practice through and in the context of a multidisciplinary care environment reduces healthcare costs. It enhances care experiences for consumers. It also improves the experience that healthcare professionals have of their work, and that has obvious benefits for attraction and retention, and also promotes and advances health equity. From the evidence review, we see similar findings. There's a lot of evidence that says this will improve access to care. It will produce equal or better outcomes than the status quo. There's some pretty good solid evidence of cost savings, and also an improvement in access for people living in rural and remote or medically underserviced areas. So that's really what the issues paper kind of summarises, and the final report will probably say essentially the same thing. Next slide, thanks. In the earlier phase, we identified 5 themes that we were exploring, and we certainly have done that through our submission processes and consultation processes to date. We looked at legislation and regulation, employer practices and settings, education and training of health professionals, funding and payment policy, and technology. They were the themes that we've been working on to date. We go to the next slide. Issues paper number 2 kind of consolidates those now into 3 themes, and they interconnect with one another. Workforce design, development and planning, legislation and regulation, and funding and payment policy. And within those three overarching themes, we've outlined 8 options for reform. They are somewhat independent, and there are also very distinct and specific elements of each of these options. And combined, they should enable full scope of practice at the individual, profession, team and systems level, and deliver the benefits that we've already identified through the previous slides. Next slide, thanks. We have the 8 reform options presented on a single slide, and you'll see that National Skills Capability Framework and Matrix, that's one of the 8, but it's also pretty much a foundational and kind of capstone area of reform that directly influences the other 7 areas. And I'm just going to quickly step you through those one by one now. And then once we've gone through those, I'll be able to hand back to Elizabeth to facilitate some questions and discussion. Next slide, thanks. So the first area, the first theme is that of a skills and capability matrix and framework. So the policy problem that we identified, and this was a very strong theme, particularly from consumers, both in the CHF session that we had a couple of months back, but also from the consumers that attended the other face-to-face sessions. The policy problem we're trying to resolve here is there's pretty poor recognition of primary care health professional skills and capabilities, and this impedes the trust that's needed for effective multidisciplinary team care, and also limits our ability to accurately plan our health workforce for the future. The option that we've outlined is a national skills and capability framework and matrix. And what it essentially does is it defines the required health workforce capabilities that are needed to meet population needs. And as I mentioned a minute ago, this option is assumed to be foundational to all other reform options. We'll just go to the next slide and break this one down a bit. So we talk about a framework and we talk about the matrix. The framework provides the terminology, and I'll step through those terms in just a moment. It identifies the sources of information that we'll need to build a matrix. It provides a visual representation of the totality of skills, capabilities, and competencies needed to serve needs. It'll provide guidance about how to use the matrix, and also points to the potential uses of the matrix. The matrix itself, on the right side of this slide pack, does 2 things. Firstly, it highlights the profession-specific skills and capabilities right across the full health and care workforce, but also identifies a number of those that are common across multiple professions, because while some skills are largely unique to individual health professional and health worker types, many skills are common across those health professions. And the second thing that it does is it enables visibility for consumers, and also for the professions and the system as a whole. Offers visibility and an understanding of the overlapping scope of practice that will help us to better inform workforce planning. It does this at 2 levels. We propose that it would do this at 2 levels. At the professional entry level, and that enables us to most efficiently and effectively train all the different types of workers and professions that are needed. And secondly, it also focuses along the professional continuum. That is, when health professionals and health workers have completed their training got the necessary registration, have a few years under their belt to kind of stabilise and consolidate their skills. It begins to recognise advanced roles that all professions have. And the contribution that we see it making is, these aren't in order of priority, but firstly, it informs and runs in parallel with the very significant investment in digital capability for the health system. It helps us to shape and identify emerging professional roles. It informs accreditation standards for the training of the health workforce. It enables us to better respond to emerging community need, because we've got a much clearer understanding of what the totality of the health workforce is capable of doing. It contributes to health workforce sustainability, and will also enable us to plan the workforce a lot better. Next slide, thanks. The terminology we use here, just focusing on three key terms: skill, which is the ability that enables specific tasks to be performed. It's typically acquired through education, training, and professional experience. An example of a skill is being able to inject a medicine. Capability is a blend of personal and technical skills, knowledge, and behaviours. It's also refined more through professional experience and sometimes additional training. And an example of a capability is determining the correct medicine to administer according to the specific needs of the patient or the consumer, and the particular factors that are relevant. And the third area is a higher order concept of competence, and that's really about the practical application of skills, knowledge, and attributes in the day-to-day work setting. It's typically refined through ongoing experience and interaction with colleagues in the multidisciplinary team. It's an indicator of proficiency. It's often used as an assessment tool, and is also an important point for providing that assurance to consumers that the workers are skilled and competent to be able to do what they need to be able to do. So an example here is being able to use those skills and capabilities to correctly diagnose illness, and to determine the appropriate medicine to administer while managing and responding to patient concerns. Next slide, thanks. The second and third reform options are again under the broad theme heading of workforce design, development, and planning. And certainly what we've identified both through the literature, but particularly through consultation and submissions, is there's limited focus on primary care and the entry-level curriculum for many of the health professions. There's often inadequate support for health professionals in developing and applying their training in primary care. And so typically a lot of their training is involved in the hospital environment. So this also manifests itself in the post-registration or the early career phase of health professions, where there's a natural gravitation towards working in a hospital environment, and that's great. We need people to work in hospitals, but we also need people to feel comfortable, competent, and have opportunities to develop and build their skills in the primary care setting. So the two options that we put forward to develop primary healthcare capability, particularly in the professional entry training arrangements through curriculum design, stronger support for supervised practical training, and also greater exposure to interprofessional education, those skills that apply across professions. And the third option is to really apply these in that kind of post-qualification and post-registration phase, once the health professionals out practicing, to give them the necessary support, training, and supervision to keep their skills up and hopefully to develop advanced skills in the primary care setting. Next slide. We change tack and focus in the legislation and regulation space. And we've put forward 3 options here. The policy problems that we clearly identified, and we certainly heard from consumers, was pretty prescriptive legislation and regulation indirectly limits scope of practice and often works against the generally enabling kind of intent of the national registration and accreditation scheme. So there are other factors beyond the national registration scheme that limit scope of practice. Secondly, it's not really responding quickly enough to emerging evidence and innovation in scope of practice. That we can see a lot of advancement at the profession level and at the service delivery level, yet the regulatory settings are not really keeping in touch with that. And a third policy problem, which is, I guess, a very specific example of this, and that is that state and territory drugs and poisons acts in particular are inconsistent. And you see different applications of scope of practice across jurisdictions simply due to the regulatory settings. So we've identified 3 options. The first one is to build on the protection of title approach that we've got. And by that I mean if a person calls themselves an optometrist or a physiotherapist, then there's a legal definition of those, and the community can be assured that they've met certain requirements to be able to call themselves that. But also to complement that with a risk-based approach to regulating scope of practice, particularly where it actually is a scope that's shared by professions. Option number 5 proposes an independent body to continually assess the evidence and to provide advice to government and to the regulators around innovation and change in health workforce models. It takes a long time to get these sorts of scope changes through, and I think the best example we see of that is prescribing, which has been a long, drawn-out battle to get to where we are now. And there are other areas of innovation that could benefit from a much more systematic approach to assessing the evidence. And of course, the 6th one is harmonising drugs and poisons regulation to support a dynamic health system, nationally consistent, and enabling mobility of health professionals across borders, but also for consumers who travel and may need at short notice to access medication and find themselves subject to different rules in different jurisdictions. And the next slide takes us into the final theme, and that is funding and payment policy. Policy problems that we identify here are that the funding and payment models, in particular fee-for-service, doesn't really support health professionals, apart from doctors, to work to their full scope of practice in multidisciplinary care teams. And secondly, the MBS payment rules, coupled with inadequate digital infrastructure, severely restricts health professionals' ability to make direct referrals. The example we give here is, a musculoskeletal physiotherapist who clearly needs an orthopaedic consult to be able to, safely progress treatment for the patient. They know it needs that sort of assessment, yet it requires a referral back through a general practitioner. who then refers the patient to the orthopaedic surgeon. The report comes back through the GP, flows back to the orthopaedic surgeon, often several months later, and at considerable expense and inconvenience to the patient. And then the physiotherapist can safely kind of, commence the work that's needed. And that's really, that's an MBS rule. It's got nothing to do with the competence and skill of the physiotherapist to make the referral. It's simply a payment rule that says that must go through a general practice gatekeeping arrangement. We've put forward 2 options for reform here. Option 7 proposes significant changes and improvements to funding and payment models to incentivise multidisciplinary care team work and also health professionals to work to their full scope of practice. So we propose 3 options, 3 sub-options. The first one is a increased blended payment arrangements so that care can be delivered more flexibly, potentially by a number of different health professionals, and doesn't necessarily require an MBS item to be raised for every single service that's delivered. The second sub-option is to adopt a single payment rate for effectively identical services that are provided by different health professionals. Vaccination's a very good example of that. And for midwifery and for, normal natural birthing, a bundled payment arrangement which joins up the various funding and payment arrangements from the antenatal period through to the hospital phase and antenatal. And the final option for reform is to enable, in certain circumstances, direct referral pathways through to specialist services that would be supported by digital technology. So I think we'll just move on to the next slide, and I'll hand over now to Elizabeth to begin the question and answer and discussion phase.
Thank you so much, Mark, for that very clear and quite thorough run through of what has been actually an incredibly intense program of review and consultation. So it's no mean feat to get all that into 15 minutes. So thank you so much for sharing that. We've got some questions, as you're aware, from people who registered for the webinar. They fit under a few different themes. So folks that are online, if you sent in a question, I've got a whole lot of your questions here. I don't have your names next to them. So you might hear your question and not hear your name next to it. But be assured they are here. And sometimes several people ask very similar questions. So it might not be your question. 4 people might have asked about the same issue. So I'm going to start, Mark, with a question, I think, or kind of a general area that is really important for health consumers. We hear about it every day, and it's affordability.
Yep.
So in relation to this work, that's really about funding reform.
Yep.
So you talk a little bit about that too, and what you've just said. Clearly there's some need for some review of the way that money can flow within health, so that different people can be funded to do different work. So there's a bit of a question about, well, okay, so how will this actually work? How will the review help? Because we already know this is a problem. This is, if you like, this was around, even in like HWA. I mean, this is not a new thing. The idea that the MBS and other funding mechanisms don't allow people to work to scope.
Yep.
So how is this review going to be different, and how, if at all you can you guarantee that people will see meaningful change through reform of funding that sits in alignment to this piece of work?
Sure. Look, as I always say when asked the guarantee question, you can never guarantee anything. So I won't be offering any guarantees, particularly as I haven't presented the report yet, and the government hasn't considered it. But look, assuming some of these reforms go ahead, and I'd certainly hope they get consideration and approval. I think one of the most obvious areas of this issue of affordability is that, and I'll choose my words carefully here, generally speaking, if your primary care need can be met fully by a general practitioner, then in most parts of Australia, there's a not rural and remote, and certainly not outer metropolitan, but in most parts of Australia, the co-payments to see a general practitioner for routine care are generally affordable, and certainly for people on low incomes, bulk billing is at high levels for a number of services. So the actual practical affordability for the consumer is reasonably good if your care needs are able to be met by a GP. When you start to get into care needs that cannot be met by a GP, and we get into the mental health space, we get into the musculoskeletal space, we get into a whole range of other areas related to nutrition, and even preventative health, there aren't really all that many payment options through the MBS system to enable people to have affordable access to those sorts of critically important care options that a GP can't necessarily fulfill. So one pathway is to simply add more and more items to the MBS, and bring a whole pile of health professionals into the MBS scheme. And while that may improve kind of affordability for the consumer, in of itself, it does nothing necessarily to promote teamwork, and doesn't necessarily enable full scope practice. So what we've done, particularly in the funding and payment options, is to look at a much more significant component of the revenue going to primary care coming in the form of flexible blended payment arrangements. And essentially what that should enable is that the health professionals, in particular GPs, to be able to make decisions on the sort of care that people need, not based solely on whether they have to issue another MBS item or deliver another MBS service. They can look at alternative options, which could be care that's provided by a nurse, care that's provided by a peer worker, care that's provided through digital means, through having access to a portion of their revenue coming through a blended payment model as opposed to fee for service. So I think it offers some hope there. Direct referrals, there's clearly going to be an affordability benefit for the patients that will be subject to a direct referral arrangement, where they wouldn't need to necessarily find and go back and see another GP. They would save time, and certainly there would be, one or two less consultation fees to pay there. But I have to say, affordability is not the overarching goal of this work, but it's a very important consideration in the Strengthening Medicare Report. So that's a fairly long-winded answer to that question, Elizabeth.
It was very detailed and very transparent, so very much appreciated. Can I just clarify, Mark, when you talk about flexible bundled payments, for the consumers on the call today, are you meaning things like the way the government uses that in aged care and the NDIS, where the consumer has control over that bundled payment? Or are you thinking it's something like perhaps reforms have seen in the past, where the money goes, say, to the general practice or your primary caring clinician, who then gets to determine what your care might be able to look like?
Look, it's one of the things we want to explore in this consultation process. The way we've described it in the issues paper is that we think that there are a lot of individual kind of sub-programs. There's PIP payments, there's WIP payments, there's Section 19 exemptions, there are the chronic disease management items, there are the better access to mental health items, all of those that are they're good in that they do provide additional services, but they've all got their own kind of red tape associated with them. And what we would like to propose, or what we have proposed, is to blend some of those into a more flexible payment arrangement. I think to then, once you've got that in place, it's a lot more, I think it's a lot more plausible and feasible to explore some of the other options, some of the more positive aspects of the NDIS arrangements, where you could hopefully tailor a package of care that's more focused on the individual consumer's needs than what the payment mechanism allows for. But I think that's a step further down the track. I think getting the funding much more flexible in the first instance through a blended payment arrangement, we think is the good first step. But we really want to explore that aspect that you raised there, Elizabeth, during the consultation phase.
Great. I'm going to move off funding, which may be a relief to you, and talk about health equity.
Mm-hmm.
So you mentioned that affordability is really important, but it's not one of the major planks of the review. Could you talk about health equity and how important that is in this review, and whether this review might lead to improved health equity, particularly as you said, those mobs you mentioned, like people in the bush, and there were others who right now their access is definitely poorer.
Yeah. Look. I think that's right. Particularly, we're using rural and remote as an example. There are highly skilled, highly competent health professionals that are both trained and regulated to provide a much more comprehensive package of services to people in areas where GPs are not necessarily available or not comfortable in providing services, and they are unable to do that predominantly through funding and payment policy restrictions, and also to a certain extent kind of regulatory gaps and education and training gaps that don't enable them to do that. So if you can remove some of those barriers, you can have a broader range of health professionals kind of step up to their full scope of practice. You can also, in the fullness of time, make it much more attractive for people to practice to a full scope in the bush, and this includes general practitioners who have a fairly restricted scope of practice as doctors, but we see in certain parts of Australia where you've got rural generalists practicing, you have effectively got GPs that are providing services to a much more fulsome scope that are able to sort of address that kind of equity gap in the bush. I think unfortunately there's always going to be a shortfall in health professionals, and that shortfall will fall more heavily in rural and outer metropolitan hard to service areas. But that problem is, I think, always going to be with us to an extent. But we can address the barriers that stop those workers who are out there and who are keen to provide services out there from being able to practice right up to their the fullness of their scope.
Great. And I want to just mention something. The next question actually relates to something you just said, so a great segue, thank you, which is around prevention. You said, we won't always have enough health professionals. So in the work that you're doing, how much of the focus is not on, if you like, kind of clinical services like an injection or a prescription, but also ensuring that people who are working to their scope can also be doing health literacy, health promotion, self-care, education, all of those things to reduce the load and, of course, then improve access overall?
Yeah. Well, the main barrier to that, Elizabeth, is not the skill and the interest and the concern of the health professionals. The main barrier to that is that there isn't a funding and payment mechanism that supports you to do that. So there are a number of kind of specific program programs that are put in place to address that in part. We see that in the Aboriginal community control sector, where they do have more flexible funding arrangements. They can focus more broadly on that holistic preventative side of things. But, you know, the reality is, in typical general practice, is that, doctors will do what they're paid to do, and other health workers will do what they're paid to do. But if there isn't a mechanism that actually incentivises a payment incentive that incentivises prevention, then it will be out prioritised by other more urgent acute clinical conditions. So I think getting at the funding and payment mechanisms is a really important part of giving people, practitioners, the time, the flexibility and the licence to be able to do what they really should and want to do, which is to prevent people from becoming ill in the first place.
Great, thanks, Mark. So there was a question, I think, in our last webinar that talked about you increase the scope of someone, I don't know, a GP pharmacist, and then maybe you don't need a multidisciplinary team because now that person can do a lot of those things, versus the conversation about having a multidisciplinary team in place.
Yep.
So does that mean that in the city, what you'll be, the change in scope might lean to better access to multidisciplinary teams, but in areas where workforce shortage is high, it might mean the scope of an individual is more increased. So you'll end up, again, kind of almost with two kinds of care. Yep. The kind of care in the city where you have a lot of people doing little bits, and the kind of care in other places. And it might be in the city, it might be in aged care or in disability or wherever else, where you have one person who's got more scope. You get a better sense now of how that's going to play out, that tension?
Yeah. Look, it's a really good question. Look, I think there's a huge amount of care that's delivered that is simple, straightforward care that only requires a single type of worker to be able to deliver it. And for most people, that's probably all they're going to need most of the time, right? So for that type of care, let's call it common or garden variety episodic care, then there are enormous benefits in enabling the provider of that episodic care to be able to do more and do it safely. And a good example of that, of course, are these pharmacy trials that we're seeing, where they're not doing everything. They're doing stuff that's within their scope, but they can do more of it, and that kind of takes the burden off overall. So you get that benefit in that. But the other part of the system, which is where people who have, and certainly many of the people that your organisation spends a lot of time advocating for, which are people with chronic complex conditions of all types, where their care needs are broader than what one single practitioner can do, whether they're working to full scope or not. It's really about multidisciplinary team care and also having nurses, nutritionists, physiotherapists and GPs, working to address the kind of holistic needs of the patient. That will be addressed by having funding and payment mechanisms and also regulatory and professional training standards that enable people to kind of do that at a team level. And that you're training people right from the beginning of their courses to work in that particular interprofessional and multidisciplinary context, and you provide ongoing support for them to do so. And that's where option 2 and option 3 in the 8 packages are really important. So the short answer is it addresses both, but I think we need to make sure that where support is provided for expanded or fuller scope, that it must be within the context of a multidisciplinary team to make it most effective.
Right, and I think you've answered Heather's question. It was in the Q&A, which was about whether or not your reviews would promote things like accessing mental health support through a range of different health professionals, including clinical nurse consultants and others. So I think you've answered that in yes, that would be the idea if that was appropriate and the person needed that support. Yeah. And again, you've segued into the next area, which is about professional education and credentialing, because there are a few questions about how will I know as a health consumer that the person that's now doing 17 things is trained in those 7? How do I choose them, knowing that they have that capacity? How am I satisfied that my care is safe?
Yep.
Can you talk us through how that might be addressed?
Yeah. So that really takes us to option number one, which is the skills capability framework and matrix, and really that arose out of kind of two concerns that came through our consultation phases. Firstly, the consumer's concern that, in fact, I'll slightly misquote you, I think, Elizabeth, but yourself or one of your leaders said, "I care less about the title of the person who delivers the care, but I do want to make sure that the care they deliver, they're competent, skilled, capable, and regulated to do so." So I think that's that's in many ways is one of the drivers for this notion of mapping out the skills, competencies, and capabilities of all of the different professional groups, and in particular areas of overlap. It makes it more transparent for consumers. But also the second benefit, which is again what we certainly identified through the first and second round of consultation, was that many health professionals have a limited or less than fulsome understanding of what some of their colleagues are capable of doing, either through the way they're trained in separate silos, or they're not working in teams to get that kind of day-to-day understanding of what a physio can do in the case of chronic knee pain, for example. So I think that option in particular, which is why we've put it as the kind of capstone in many ways, is critically important, because it calls out and transparently identifies what the range of skills and services and competencies that are required for a community, and which of the professional groups are able to do some or none of that. And at the moment, you can't find a single document. You cannot find an authoritative source that makes that clear to the consumer. We rely very heavily on the regulatory arrangements we've got in place that says, well, if I'm a doctor, of course I'm trained to do this. I know exactly what I'm doing. But I think we've moved beyond relying on just that title. I think a little bit more transparency is well overdue.
Yes, I think trust more broadly in the community has reduced over years. And yeah, maybe 50 years ago, someone was wearing a white coat with a stethoscope, you would have just assumed that, first of all, that they were a doctor and that they knew what they were doing, and less and less so people would take that view. Thanks, Mark. There are a couple of questions around harmonisation, and you did talk about this harmonisation, not just from the drugs and poisons perspective, but more broadly with things like other reviews, whether it is the Strengthening Medicare work or the HTA review, goodness knows. Can you talk about how your report will talk to that need for coordinated or harmonised reform?
Well, look, the starting point is the Strengthening Medicare Taskforce Report, which is a great overarching framework. So whatever we do has to be in alignment with that. But certainly from day one, and we've had great support from the health department in particular, there is a number of coordinating mechanisms that have been established to ensure that the work that I'm leading in this review is informed by other important areas of work. There's a review, or there are over 30 individual measures or reviews or pieces of work, reform work, that are underway at the moment that I'm aware of. So we have kind of regular coordination meetings and discussions with the other relevant areas, and we've got our own kind of mental checklist that we apply to make sure that all of these reforms, are at least informed by and hopefully can articulate with the other measures. So it's been something I've been very focused on from day one. I can't guarantee that I'll know absolutely everything about every review that's going on, but we've certainly had a lot of good support and great engagement from all of the people that are involved in those other measures or other review efforts that are underway.
Thanks, Mark. And I'm sure that your deep network in the department and also your experience in a health department allows you to proactively think about the best way to bring all of those different kind of teams in the department together. So fantastic. You did mention in your work, you talked about a body to assess evidence for innovation and change, and you've made some other comments about governance.
Yep.
Can you talk to me about how you see consumers being involved in those governance mechanisms from the top, whatever that looks like, through to the bottom?
Yep. Yeah. So we want to explore that in a lot of detail in the consultation sessions. So, we've identified a couple of different ways that body could be constructed. But increasingly we're seeing with a number of the other kind of similar type bodies that the department has, PVAC, MSAC, and some of the other, the Medicare Review Advisory Committee. There are, elements of consumer engagement involvement associated with those. Perhaps not as fulsome as consumers would like, but I think this is an opportunity to propose the design of a mechanism that ensures that consumer perspective has as much weight as any of the other technical or kind of professional inputs into it. So, very keen to explore that in this consultation phase. We have no firm view on how that body would be constructed at the moment.
Well, it sounds like the roundtable coming up is going to be just fantastic with all these very important issues that you'll be exploring with our consumer colleagues. So when we're nearly about to finish, I'd encourage you to put any last comments in the chat that you have. If you want to send Mark some love using the reactions, I'm sure he'd be very happy to see that. We did this recently with the Minister, Mark, and I said, "Did you like that, Minister?" And he said, "I'm not wearing my glasses, so I can't really see it." But you are wearing your glasses, so if anyone sends you a party, a heart, or a smiley face, you will hopefully be able to see that, or a thumbs down, or whatever it is.
Okay.
So I first of all like to thank you for your time again today and your willingness to discuss these really important issues for consumers so genuinely and transparently. I'm sure everyone here has greatly appreciated that, and you'll see that in the chat too. I'm going to throw to you to a final comment, and just to mention that we will have the expression of interest for our roundtable out to you shortly. So any last words, Mark?
Great. Look, thanks very much again for the opportunity. I'd really encourage you to stick with the engagement. I know it's really hard, particularly when there are a lot of other powerful vested interests, and we're seeing them kind of emerge here pretty strongly. The best kind of balancing mechanism for that kind of unproductive turf war stuff is to have a visible, strong consumer voice saying, well, hey, you guys, you can slug it out all you want, but what about me? What about the people I represent, the families that I support? And I think that's, I just strongly encourage you to make the most of this engagement process, and make your views known by whatever means you deem appropriate.
Fantastic. We'll all be on the 7:30 report tomorrow night talking about this, Mark. Again, big thanks to you and your team, and also to the amazing team at CHF, James, Lisa, and many others who've been involved helping us get today online, and hopefully of value to you all. We hope that the rest of your day is good and that you go well. Thanks so much for joining us.
Thank you.
If you're still here and you want to have a play with your phone and try and click on that QR code, you're really welcome, but we will send out the link too. Thank you so much, folks.
Cheers. Bye-bye.
Bye.